Okay. Now it is 8 p.m. Local Cairo time and the local Medina time, and it's 9 p.m. in Nairobi. It is the time to start our very interesting event. All of our dear valued attendees who have registered for our meeting from 14 different countries all over the world. Here we have the East meeting the West and the North meeting the South in the Uchid conference, pre-conference workshop titled the HIV medications and weight gain in the low to middle income countries. We are talking mainly about Africa. Me, I'm Ahmed Kurdi, lecturer of endemic medicine at Cairo University and the coordinator of Qasr Al-Aini HIV and viral hepatitis fighting group. And I'm delighted to be the moderator of this session with Professor Rina Shah from Aga Khan University in Nairobi. And in Uchid, we always believe that collaboration is the golden key for innovation. And I will not waste the opportunity to invite you all to join us at the third United Conference of Hepatogastroenterology and Infectious Diseases, the virtual conference that's coming from the 5th to the 7th of November. Please join the website to do registration for our conference. And today we are talking about the weight gain and HIV treatment. And if you are wondering why we are talking about this topic, you need to know that the recent studies have reported that 1 in 6 people who have started HIV treatment, at least they have 10% in body weight increase over 1 to 2 years. And this weight gain was mainly noted in the Black women and the people who have started treatment in more advanced disease with lower CD4 counts. And this is the case in a lot of our countries where we don't have very well established screening systems. So we have a lot of patients who are come in more advanced disease. And here in Africa, we have a lot of the Black women and Black people. Also, the weight gain is associated with specific anti-HIV medications. All the evidence is pointing toward the integrase inhibitors and with focus on the dolutegravir and the tenofovir alafenamide. And nowadays, in our countries and in Africa, we have a major shift toward the transition toward the dolutegravir. I can tell you that a few days ago, I was congratulating our colleagues in Algeria that we are by the end of our fight to have the dolutegravir available for the Algerian people. Now they already have a voluntary license to have the dolutegravir in affordable price. So we are fighting to have the integrase inhibitors for our patients. And that is because the fact that dolutegravir is more potent molecule can help us to achieve more rapid viral load suppression. And on the other hand, it has very high barrier to resistance. So it is suitable for our condition and our countries. And in Egypt, we have the national guidelines that started to put the dolutegravir as one of the, or maybe it is the first line of treatment for the Egyptian patients starting from December 2017. So we have today have addressed in this meeting what is the conflicting data and a lot of data and the appearing now every now and then in the literature talking about the possibility of weight gain and the possibility of development of diabetes and their consequent metabolic disorders. And in our countries in Africa, you know that we have high rate of diabetes, high rate of obesity. I can say that Egypt is one of the top 10 countries for the diabetes diagnosis, and Egypt and South Africa, they are one of the top 10 countries for the diagnosis of obesity. So we have to talk about this topic. And it's my pleasure to introduce our valued chairpersons. We have Professor Amgad Al-Zahabi, Professor of Hepatogastroenterology and Infectious Diseases at Al-Azhar University. Dr. Amgad is one of the main members of the scientific committee for the National AIDS Program in Egypt, and he's a member of the steering committee for the Uchid conference. And Professor Godfrey Lulu is Professor of Internal Medicine He is working since long years in the HIV medicine, and they have very good experience in the development of the Kenyan guidelines about HIV. So we are welcoming them to lead our meeting today. And now I don't want to waste more time of our interesting meeting. I'm leaving the floor for Professor Amgad to start to introduce the speakers and start our interesting meeting. Please use the Q&A button to leave your questions. We need to have a very interactive session today and to exchange the experience with our colleagues from Africa and from Europe. So please leave your questions, and it will be very nice to have this. Dr. Amgad, the floor is yours.
This introduction, I would like to take the chance to welcome all the distinguished speakers and the distinguished chairpersons of this important session. I would like to welcome Professor Maisa Shawqi from Cairo University, and Professor Heba Abdullah from the Ain Shams University, and Professor Giovanni Goraldi from Italy. Also, I'd like to welcome my colleagues, the chairpersons of this session, Professor Rina and Professor Prost Lulu, and thank the EVA company for sponsoring this meeting. So let us take the chance to welcome Professor Maisa Shawqi. She is a professor of public health and the head of the public health department in Cairo University, and she will give an interesting talk about the diabetes, obesity, and metabolic syndrome in Africa. So please, Dr. Maisa, Professor Maisa. Okay. I would like to welcome Professor Heba Abdullah. She is Professor of Tropical Medicine in Shams University, and she will give an interesting talk about the metabolic syndrome and diabetes mellitus among the people living with HIV. So please, Dr. Heba.
Dear colleagues, my dear professors, chairpersons, moderators, to give me this opportunity to share in today's event. My talk will be about the risk of diabetes, NAFLD and NASH, and weight gain in people living with HIV. Today is a distinguished, unique date. I think Dr. Kordi chose it specifically, 2010-2020. It will be a date to remember. Now, about the epidemiology of obesity in people living with HIV, we all know that the proportion of overweight and obesity in people living with HIV has increased globally. In one study from the United States, the prevalence increased from 28% to 51%. And in another study, the percentage of obese individuals at start of the antiretroviral therapy increased from 9 to 18% over a period of about 12 years. It was found that people with normal body mass index after start of the antiretroviral therapy by 3 years, 22% of them become overweight, and 18% of those with overweight become obese after 3 years of the start of antiretroviral therapy. Now, several anthropometric indices are available to characterize the adiposity in people living with HIV. The most important is the measurements of the central adiposity. It is most strongly associated with the risk of the cardiometabolic disorders. Coming to the top of these indices is the CT imaging. It offers a superior quantification of adipose tissue components, and it is used increasingly in the research settings. What about other indices? The body mass index, it is an anthropometric measurement commonly used in the clinical and research fields. The higher body mass index, of course, is associated with the cardiometabolic diseases, including diabetes and the cardiovascular disorders. but it poorly discriminates between the lean and fat body mass, which can be influenced by multiple factors. What other indices that can be used? Some indices can be used to estimate the visceral adipose tissue compartment, and it can predict the risk of cardiometabolic complications better than the body mass index. Usually, people living with HIV more commonly have the visceral adipose tissue expansion, but these parameters or indices are imperfect and they cannot assess the relative contributions of the subcutaneous adipose tissue and visceral adipose tissue to the increased waist circumference. What are these indices or what are these parameters used? The MRI and CT imaging, they are gold standard for quantification of the adipose tissue, whether subcutaneous or visceral, but they are used in the research purposes. On the other hand, the dual energy X-ray absorptiometry can also quantify the total trunk fat mass, but its software for estimating the visceral adipose tissue often provides underestimate results compared to the CT imaging in people living with HIV. So it remains the adipose tissue biopsy, the standard practice for assessing adipose tissue morphology. Now, what are the risk factors associated with weight gain in people living with HIV? Here we can see these integrated processes. They are the hallmark for the development of obesity and the resulting comorbidities from it. We know that the associated wasting syndrome of HIV, characterized by anorexia, secondary to the effects of the elevated inflammatory markers due to the continuous immune activation by the viral proteins. There is increased basal metabolic requirements, which can exceed 30% of the basal points during the secondary infections, and a catabolic state resulting from increased protein turnover. Now, with the start of antiretroviral therapy, this process is reversed, and this adds to the start of obesity. Together with the obesogenic environment, the aging population, we have the obesity with this process, which is the hallmark for the development of all cardiometabolic effects. We have inflammation, altered lipid and glucose metabolism, and ectopic lipid deposition. Resulting in multiple comorbidities, we are going to focus mainly on diabetes mellitus and hepatic diseases, but we also have the neurocognitive impairment and the cardiovascular disorders. As regards the antiretroviral therapy, the older NRTIs and NNRTIs show no weight gain. The protease inhibitors give mixed results about the weight gain, but the greater weight gain was reported with the use of the integrase inhibitors and their based regimens. Also, as Dr. Kordi mentioned, the use of tenofovir alafenamide also predisposed to weight gain independently of use with the integrase inhibitors. What is the mechanism by which antiretroviral therapy produce weight gain? It is incompletely understood. It may be mainly due to decrease in the catabolic state and the continuous immune activation caused by the virus. The genetic polymorphism may have a role, and it is not well known if we change from one regimen to another, does this reverse the weight gain or not. Now, what happens in the adipose tissue? In HIV and obesity, adipose tissue usually shows two important things: altered distribution and deposition, as well as increased inflammation. Why this occurs? This occurs mainly due to viral proteins. These are samples of the viral proteins, like the HIV viral protein R and other proteins. They produce alteration in expression of adiponectin, lipoprotein lipase, the glucose transporter type 4, and other mediators, which cause changes in the adipocyte function. And this is the start point for the whole process. If we take a sample or a biopsy from the subcutaneous adipose tissue from untreated person with HIV, we will find what's called the mitochondrial DNA depletion in the cells and reduced function of several mitochondrial enzymes important for the aerobic metabolism. This is what's called the lipodystrophy. And this lipodystrophy results in, or is associated with, higher rate of total lipolysis and increased free fatty acid levels, reduced postprandial clearance and storage of plasma triglycerides, increased rate of intrahepatic and intra-adipocyte fatty acid esterification, and increased de novo hepatic lipogenesis up to 3 to 4 folds. This process will lead to increased ectopic fat deposition in the liver, epicardium, skeletal muscles, and increased risk of metabolic diseases. As we know, the people living with HIV on antiretroviral therapy usually has increase in total body fat in the trunk and lower percentage in the limbs compared with those negative for HIV. This is due to impaired energy storage in the subcutaneous adipose tissue, as well as the less exposure to the toxic effect of the antiretroviral drugs and the virus itself that occurs in the visceral adipose tissue than the subcutaneous adipose tissue. So there is expansion of the visceral adipose tissue and other ectopic adipose deposits. This is the integrated process, starting with the immune activation, insulin resistance, passing to the dyslipidemia, the visceral adipose tissue increase, NAFLD, which is considered the hepatic manifestation of the metabolic syndrome, and diabetes, together with the cardiovascular diseases. Talking about the two important issues of our talk today, diabetes, its incidence in people living with HIV increased. It is reported to be 3.1 to 14 cases per 1,000 patients per year, and there is over 4-fold higher percent of diabetes in HIV positive than HIV negative individuals, and the incidence of the prediabetes is reported to be 125 cases per 1,000 patients per year. The risk of diabetes with weight gain is higher in people living with HIV. We have that they have about a 14% increase in the risk of incidence of diabetes compared to just 8% of HIV negative individuals with each 5 pounds increase in their weight. The traditional risk factors for diabetes occur in the general population and the people living with HIV, like the older age, the increased body mass index and central adiposity, the family history of diabetes, but there are some factors specific for HIV, like the lower baseline CD count, CD4 count, the use of older NRTIs and protease inhibitors, and it is mainly related to higher circulating inflammatory markers. Now, what about the hepatic disease? We are talking about the non-alcoholic fatty liver disease, which is a huge or great spectrum of diseases. After the start of the antiretroviral therapy, the all-cause mortality in people living with HIV is low, but the liver-related complication remain one of the major causes. And after introduction of the effective antiviral therapies for viral hepatitis, it's likely that fatty liver diseases will be the major leading cause of liver cirrhosis in people living with HIV, as it is occurring in the general population. Of course, there are some concurrent diseases like the alcoholic liver disease, the drug-induced liver injury, and the co-infection with hepatitis C. NAFLD, we define NAFLD, or it is characterized, or the components of NAFLD, hepatic steatosis involving more than 5% of hepatocytes after exclusion of secondary causes like the alcoholic liver disease or other secondary causes, and usually it is associated with components of metabolic syndrome. We have the components of metabolic syndrome: increased waist circumference, increase the fasting serum triglycerides more than 150, fasting glucose more than 100, high density lipoproteins increase in men and women, and the blood pressure of 130 or more than 130 over 85. If we have increase in liver enzymes and you are passing to hepatitis, which is NASH, non-alcoholic steatohepatitis, and if it is early with the F0 to F1 fibrosis, fibrotic NASH, we are passing to more than F2 and F3. NASH cirrhosis, which is F4 stage in biopsy, and of course, it can also be associated with development of HCC, and HCC can occur in absence of cirrhosis. In cases of NASH, there are cases reported of HCC without presence of cirrhosis. Now, the overall prevalence of NAFLD, about 25%. It is reported in people living with HIV, varying between 28 and 48%. In one meta-analysis using diagnosis of NAFLD by imaging, the prevalence was about 35%. And in another study using the elevated liver enzymes, it showed about 75% of patients having NAFLD. Now here we have the general pathogenetic factors for NAFLD, starting with the insulin resistance, the dyslipidemia, leading to lipid accumulation in the liver. But specifically for HIV, we have the HIV-related immune activation, the mitochondrial dysfunction, and the drug-induced dyslipidemia. If we take the virus itself as risk factor for NAFLD, it was found that it is suggested that the virus has its specific effect for development of steatosis. This is suggested by the histopathological studies reported high numbers of steatosis in treatment-naive HIV patients. That is suggestive of direct steatotic effect of HIV itself. And people living with HIV with NAFLD tend to have lower body mass index than those negative controls with NAFLD. What is happening in people living with HIV? We have advanced immune deficiency and ongoing immune activation. This leads to high levels of many pro-inflammatory markers, for example, tumor necrosis factor and interleukin-6, which will lead to insulin resistance, which is present in about 35% in people living with HIV. This will result in multiple things like the higher triglyceride and free fatty acid levels compared to the healthy controls, decrease the high-density lipoprotein cholesterol and total cholesterol levels. And it was found that there is established association between the high HIV viral RNA levels and the hypertriglyceridemia. If we start the antiretroviral therapy, we will stop this immune activation. So it is supposed to have diminish in the viral impact of the lipid profile. But in a certain antiretroviral therapy can contribute to the development of NASH. Why? By two different ways. Some antiretroviral drugs cause dyslipidemia and insulin resistance, and other drugs cause mitochondrial dysfunction. We will have a rapid look on these drugs. As regards the NRTIs, the early generations were commonly associated with mitochondrial dysfunction, especially, for example, the stavudine, while the modern NRTIs rarely implicated in clinical significant mitochondrial dysfunction, like the tenofovir, lamivudine, and emtricitabine. What is the mitochondrial dysfunction? Why there is mitochondrial dysfunction? These drugs cause inhibition of the replication of the mitochondrial DNA. This will lead to impairment of the oxidative phosphorylation, and there will be formation of multiple reactive oxygen species, which will add more to the damage of the mitochondrial DNA. This will lead to what's called mitochondrial dysfunction and mitochondrial toxicity. When this occurs in the peripheral fatty tissue, this will lead to insulin resistance and dyslipidemia, as we mentioned in what we discussed about lipodystrophy. And this will lead to degeneration of the peripheral fatty tissue combined with insulin resistance and dyslipidemia. And in the liver, this will lead to decreased oxidation of the free fatty acids and local accumulation of triglycerides in the liver, which is the hallmark of NAFLD. Regarding protease inhibitors, the early generations protease inhibitors showed increased risk for insulin resistance and dyslipidemia, like indinavir. Why? Due to the inhibition of the transport function of the glucose receptor transporter type 4, leading to hyperglycemia and hyperinsulinemia. And this was reported from animal studies. While the current protease inhibitors like the darunavir, for example, they display a far more favorable effect or profile as regard the insulin resistance when they are used as monotherapy. But when they are combined with ritonavir or copicistat, they will lead to the same dyslipidemic effect. What are the suggested mechanisms for the protease inhibitors induced dyslipidemia? Some data suggest that these drugs cause increase of the apolipoprotein B, which is transporter for the LDL and triglycerides in circulation, and other experimental researches suggest that ritonavir inhibit the clearance of triglycerides from the circulation. The NNRTIs, we have limited data, but for example, rilpivirine have more favorable profile compared to evavirins. Darunavir showed lower triglyceride and LDL levels when compared to evavirins and darunavir. The integrase inhibitors, they are generally considered advantageous in respect with the metabolic profile, and the other classes like the entry inhibitors, data are limited, no enough data about these drugs, but none are incorporated or implicated in the development of NAFLD. These factors we discussed were the factors related to the virus itself or the use of the antiretroviral therapy. Other factors away from those 2 points, we have the co-infection with HCV, especially genotype 3, which is characterized by development of steatosis. And it was found that after treating this virus and reaching the SVR, the degree of steatosis is diminished. Hepatitis B virus infection is less incorporated with the development of NAFLD, but now we can say that people living with HIV grow old enough to be exposed to the traditional risk factors like the high body mass index, increased waist circumference, type 2 diabetes, hypertension, and high triglycerides. How are we are going to diagnose NAFLD or NASH? As we know, liver biopsy is the gold standard for the diagnosis as it discriminates between steatosis and steatohepatitis. But due to its invasive nature and possible complications, it is not useful as an epidemiological screening tool. So what is the instrument or the parameter or the method used for screening? We can use the abdominal ultrasound. It is preferred over CT due to higher sensitivity, lower cost, and availability, but its sensitivity is limited in morbidly obese patients and in cases of mild NAFLD. So coming as an imaging technique to diagnose NAFLD, the magnetic resonance imaging modalities, magnetic resonance spectroscopy, proton density, fat fraction, and its sensitivity reaches up to 100%. Due to its low risk, it can be used in the clinical research, but it is highly has high cost and limited availability, so its use is limited to the clinical research and cannot be used as a screening tool. Now we have the FibroScan with the controlled attenuation parameter or CAP, and it is a good method for a determination of steatosis as a non-invasive method. Now we're talking about NAFLD or fatty liver disease. What about the steatohepatitis? How can we discriminate NAFLD or fatty liver from steatohepatitis? We have to find marker or score to diagnose this. But unfortunately, it was suggested to have the elevated liver enzymes like the ALT to discriminate between steatosis and steatohepatitis. But it was found that there is a proportion of patients with steatohepatitis with normal ALT level. So we had to try to find different scores to depend on for this diagnosis. We have multiple scores like the NAFLD fibrosis score. It is calculated from these components. We have the FIB4 score with its specific interpretation and the ELF score or ELF blood test enhanced liver panel for the diagnosis or the finding of the fibrosis. The transient elastography is approved for finding the fibrosis or diagnosing fibrosis. And using 9.9 kilopascal, it was used as a cutoff value for advanced fibrosis. And 7.9, it is negative predictor for ruling out cirrhosis. And it still cannot discriminate between F2 and F3 fibrosis. Now, this is the recommendations of the guidelines from the European AIDS Clinical Society for the diagnosis of NAFLD, and it is summarizing what we have mentioned about the ultrasound, the serum biomarkers, transient elastography, the use of MRI modalities, but just in the clinical research, and finally, it is the liver biopsy, the gold standard for diagnosis. Here is an algorithm must be used in people living with HIV for screening of NAFLD and for its further management. If we have a patient with HIV with obesity, metabolic syndrome, persistent elevation of ALT, or exposure to the antiretroviral therapy, with ultrasound suggestive of NAFLD, we have to determine the risk of advanced fibrosis. We have to calculate the FIB-4 and the NAFLD fibrosis score for him. Results of this score will take us to one arm with these readings, which is the low risk of advanced fibrosis, and this will be managed just by controlling the diabetes, hypertension, stop alcohol, weight loss, and assess for the cardiovascular risk and consider some indications like statin, or will take us to another arm with high risk of advanced fibrosis, and this patient will be managed as mainly a hepatic patient with assessment of liver disease by the different scores, management of advanced fibrosis, screening for hypertension and its portal hypertension and its treatment, and screening for HCC. But we still have the gray zone where these two scores, FIB-4 and NAFLD fibrosis score, cannot discriminate between low risk and high risk. This the point where we shift to the ELF score and the elastography, and the results of these two will take us again to one of both arms, and we will manage the patient according to the results. Now, despite there is extensive research over these recent years for treatment of NAFLD, it is remaining challenging. This is the European AIDS Clinical Society guidelines for the treatment, and we find these components: the lifestyle modification and weight reduction, the progressive increase in exercise with caloric restriction, and the pharmacotherapy. The lifestyle modification, mainly the weight loss, it is the most important intervention in all patients. And if we have sustained weight loss between 7 to 10% of the original weight, it is needed to improve the majority of the histopathological features of NASH, and of course, alcohol must be stopped. There is something to help the reduction of weight by the bariatric surgeries, and several studies show high rates of histological improvement in NASH in patients with significant weight loss after bariatric surgery. What about the medical treatment? One study compared the efficacy of pioglitazone, vitamin E, and the placebo in people living with HIV with their endpoint of treatment, or the primary outcome, histological improvement of histological features of NASH. Vitamin E therapy showed promising results, but still there is a fear of its association with the prostate cancer when it is taken in about 400 milligram vitamin E daily. And for pioglitazone, it also showed promising results, but there is major side effect of pioglitazone, which is weight gain, and again, a question mark about its association with bladder cancer. So we have the general recommendation from the European Association and American Association for Study of Liver Diseases, suggesting considering vitamin E only in non-diabetic, non-cirrhotic adults with biopsy-proven NASH. The use of insulin sensitizers is recommended by the EASL in patients with type 2 diabetes, and the American Association suggests its use regardless the situation about diabetes. Other drugs like the metformin, the ursodeoxycholic acid, or other alternatives cannot be recommended in the current guidelines. This is the drugs used for treatment of dyslipidemia. Specifically, when we talk about people living with HIV, interventions for controlling NASH or NAFLD include the general interventions, but we have something specific regarding the HIV and antiretroviral therapy. First, these interventions should focus on reducing the degree of immune activation in HIV infection, and this is will be achieved by the early introduction of effective antiretroviral therapy, aiming to full virological suppression and optimal immunologic recovery. Of course, we know that now we have the introduction or start of antiretroviral therapy regardless of the CD4 count, and this early initiation will stop the immune activation and help to decrease the insulin resistance, which is the point from which started all the process of lipodystrophy and NAFLD. Second, if the patient is using antiretroviral therapy regimen with unfavorable metabolic profile like the protease inhibitors or early generations of NRTIs, we have to consider a change or shift to another regimen which is not taking this hazard. What about the future expectations? The upcoming years will be characterized by the transition from the HIV and antiretroviral therapy related risk factors towards the classical risk factors for development of NAFLD. And during this, the physicians should be aware of the high prevalence of NAFLD in their patients, especially for those with who were diagnosed before the introduction of antiretroviral therapy, those starting with low nadir CD4 count, and those receiving early generations of antiretroviral therapy. About treatment, there are many drugs under investigations. We have the non-antifibrotic and antifibrotic drugs. A phase 3 study on the non-antifibrotic drug like the elafibranor, and for another category, the antifibrotic drugs. It is the seronsertib, and it is again in phase 3 study clinical trials. Now, in conclusion, life expectancy of people living with HIV has increased dramatically after introduction of the antiretroviral therapy. Liver-related morbidity and mortality continues to be a greater burden in this population. In some patients, the residual inflammation persists, and some antiretroviral therapy continue to influence the metabolic profile, and people living with HIV will grow old enough to face the traditional risk factors for NAFLD. So these developments should make us aware of the high risk of NAFLD in this population and warrant further research on modification of both the traditional and HIV-related risk factors and therapeutic interventions. And thank you very much for listening.
Okay. Thank you, Professor Heba, for this interesting lecture. Now I would like to present the Professor Maisa Shawqi. She is a professor of public health and the head of the public health department in Cairo University, and she will speak about the metabolic syndrome among people, obesity and diabetes among people in Egypt and Africa. So please, Professor Maisa.
Thank you very much for inviting me to share with you in this very important conference that's bringing light to the health situations in Egypt and in African countries. I'm going to speak today about the NCDs in Egypt in general, and I would like to pass over our success stories because this is important to share with our colleagues and nations in the African continent. I'm going to highlight the situation of the NCDs in Egypt and explain the national efforts for prevention and control of NCDs in Egypt. If you are to speak about wellness, wellness is a scope that starts from being very ill and in a pre-death phase, and it would go and escalate upwards till wellness. And usually people would consider themselves they are fine when they are in the comfort zone where they think that everything is okay. And if we undergo some screening tests or some health appraisal forms clinically, we find that we have problems that are hidden below the surface, or we call it the hidden part of the iceberg. Our aim in public health is always to promote health from the red zone to the yellow zone to the green zone, as we can see, and to unmask what is hidden, to attack it or to address it properly, and to assume better health. When we go from a health status to a better one, we call this health promotion. Health status and well-being are affected by different intermingled factors, the biological influences, the social environment, health behaviors, the economic environment, health services, their availability and their coverage, and the quality of the services, and the direct physical environment. These variables are so intermingled that sometimes each one of them holds a different weight in a specific population, or maybe by age distribution and by residence as well. It happened in the year 2017 that the WHO annual report was a little bit alarming. And from this report, a cascade of serious interventions in our country started. Figures would tell us that hypercholesterolemia was around 20%, hyperglycemia 15.5%, hypertension around 26%, and obesity around 40%. Inefficiently physically active people were 25%, which actually made physically active people, or appropriately physically active people, a little bit beside zero. The mean intake of salt exceeded 5 grams per day, and this was 9 grams per day, almost double the required amount of salt. And 90% of the studied sample in this research consumed less than 5 portions of vegetables and fruits. And smoking between the 15 to the 69 years of age in the population was 22.7%. And this was quite high, and came another figure was that the exposure to the secondhand smoke was 50%. All these figures did ring a bell and made the cabinet think proactively about what can we do to reveal the accurate numbers and to conduct the interventions, the necessary interventions for prevention and control. Along the same period after the year 2017, the WHO report for the NCD's country report in 2018 had an estimate that the NCDs contributed to 84% of the total deaths. And the probability of premature death was very high among males and females, and it was projected that this high probability of death would continue on the same extension line, both for males and females, if a serious intervention was not to be immediately installed. As for obesity and our current interest today, you can find that women are suffering much more obesity, overweight and obesity, than males. And the expectation is that this trend is going to be on the rise in the next 5 years if it is not properly addressed or seriously addressed at the same time. We have Professor Ayub Al-Jawalda has done also a research to unmask a little bit about the eating habits and what about the diet in the Mediterranean region, in the Eastern Mediterranean region. And here we can find that Egyptians in this study suffered, 40% of them suffered from dyslipidemia, and 29% of obesity, and 18% suffered from hypertension. In another study, also the total intake of fat based on the dietary assessment studies showed that the consumption of total fat was high. It was 26% for males and 24% of total energy intake for females. This is for the Egyptians in the on a subnational scale, and it was an earlier study, like pooled old studies in the year 1995. Intake of 9 grams of saturated fat per day was the average intake of the Egyptians, and this also had to ring a bell, although if we compare this figure as compared to other countries from the Eastern Mediterranean, you'd find that Djibouti had a higher consumption, Jordan had a higher consumption, Kuwait had a higher consumption, and so is Saudi Arabia and Yemen. Then a further study revealed that the total intake of trans fat was also high, very high in Egypt, and it was to be considered Egypt the first runner in the consumption of trans fat, and next coming is the Pakistani population. These studies made the Egyptian Ministry of Health think wise. What can we do for prevention? If you are to speak on the 3 levels of prevention: primary, secondary, and tertiary prevention. And the consideration here is that primary prevention is very important, and secondary prevention comes next if we are to detect individuals who are at risk. And we install for them the appropriate measures, and we raise their attention to maintain better health behaviors and to go for the regular health appraisal to confirm that they are fine. Maybe we speak a lot about primary, secondary, and tertiary prevention, and usually in public health we consider of utmost importance is the primordial prevention or the health promotion of the whole community through taking certain policies and legislations and putting them into action or enacting them in the community to help the people enjoy better quality of life. So primordial prevention is defined as the prevention of risk factors themselves, beginning with the change in the social and environmental conditions in which these factors are observed to develop, and continuing for high-risk children, adolescents, and young adults. So with primordial prevention, we install our measures a little bit early, and we enact them vigorously. In screening, we detect cases. And when cases detected, then it must be treated appropriately, and we undergo research to know more about the risk factors and the natural history of disease, and we create a mass public awareness that makes the people enacting these regulations or these measures for self-protection, and they become empowered in their decision-making based upon evidence or scientific research as guided by the Ministry of Health and contributing ministries. Health screening in general has been focusing upon diabetes and high cholesterol, upon colorectal cancer, breast cancer, screening for high blood pressure, and obesity. Lots of screening tests are available. We call them the battery for screening tests, and we usually select the test that has the high specificity and sensitivity as much as possible, and the one that when we apply it on a national scale could be performed easily and could be interpreted also with a big safety margin. Obesity has become an annoying chronic health problem all over the world. We are living in an obesogenic world or globe right now. We study usually the risk factors that contribute to it, but we would rather focus on the physical inactivity and the dietary trends or habits. These are the modifiable kinds of factors, and the consequences of obesity would hold many of the NCDs like insulin resistance and type 2 diabetes mellitus, cardiovascular diseases and hypertension, obstructive sleep apnea and hypertension again, and psychosocial problems. When we undergo the screening for obesity, we are very much concerned about the normal weight persons who are metabolically active, and these are people with the normal blood pressure, normal body weight, but they might be having central obesity. And obese, metabolically healthy ones who are not yet dyslipidemic or hypertensive or suffering from diabetes, and we are also seeking to detect the normal weight metabolically unhealthy ones because they have to be captured via the anthropometric measurements that is done in the field. Then came the presidential initiative for 100 million health, where a cascade of national screening tests has been launched, and let me tell you that it started 2 years ago and it's still ongoing up till now, with a perseverance and insistence to detect as early as possible aberrations from health or deviations from normal health for several diseases in our country. This NCD's national screening intervention aimed at detecting the hepatitis C virus at the very beginning, with detection and treatment of all detected cases, which brought down the prevalence of the hepatitis C virus to below 0.3%. 0.3 per thousand. Screening for weight and height and body mass index to detect overweight and obesity, blood pressure to detect hypertension, random blood glucose, which was when proved to be higher than normal, fasting and 2 hours blood glucose were underwent, and together with the glycated hemoglobin. Next phase included malnutrition and anemia amongst school children, with the underweight and stunting and overweight and obesity problems again surfacing in primary school children and secondary school children. This was coupled with an intervention for deworming or treatment of parasitic infestations. And currently speaking, we are inside the biggest national screening program for breast cancer. The presidential 100 million health initiative started with the training of doctors and nurses and healthcare staff upon the standardized measures for undergoing or performing the screening, about its registration, about the transfer of data or uploading of the data, and it was so systematically arranged all over the country. We have here in Egypt 27 governorates, and the national campaign was divided into 9 governorates per time or at a time. When the first phase was finished, we moved to another 9 governorates. When the second phase was finished, we moved to the third one. And it had the screening for hepatitis C virus and its management, together with screening for the NCDs and planning for a decentralized plan for each governorate according to the prevalence of the NCDs over there. This was the biggest campaign ever, where 6 million were screened. People were assigned and directed to come for the national screening. They were interviewed, screening tests were performed and registered and recorded. And we had an early report that discussed the prevalence of these NCDs in our country. The early report was, and this is not yet published, in May, was revealed in May 2019, where we had type 2 diabetes mellitus 5.2 and not 15. Hypertension was 20.9 and not 40%. Obesity was the same as it was discovered earlier, 39.6%. And if we added the overweight issue to the obesity, this figure would rise to 70. And the hepatitis C virus positive adults were 4.4. All of them were treated right now. The prevalence rate for obesity in Egypt was 40, and type 2 diabetes mellitus was 7. In another report, the prevalence of hypertension was obviously higher in the urban communities, both for males and females, as compared to the rural communities. The urban communities, both females and males, were higher in the average blood pressure, in the prevalence of the hypertension amongst. We have spectrum of opportunities. If we tackle obesity, then we are going to tackle also its metabolic consequences. And this set of array, which is right now put on this on this slide, would tell us that we are to go for more regulations and legislations and policy directions. We should attack, or we should direct our attention to children and adolescents and adults, and we should speak about physical activity and healthier choices for their food. Funding and assistance or finance, pre-service and professional development and training, facility level interventions at the primary healthcare or at the secondary level of healthcare services, providing technical assistance and access to healthy environments. And this was a great move in several governorates in our country where walking tracks have been identified and secured for women and for young children to go for their walks or even to go running. We have a movement for women on the bike without being harassed or attacked by others. And this physical activity movement is actually enlarging day after another. We have the family engagement, and we are all the time seeking for the emerging opportunities that can enact better environment and better support for the prevention of the NCDs in Egypt. Social marketing invaded all the campaigns on the TV, on the radio, on the press, and also on the billboards in the street for healthier choices, with a special focus on vegetables and greens and fresh fruits rather than junk, and how to select the leaner kind of meat. At the same time, it was also directing the public to refrain from adding salt, from lots of caffeine and stress and lack of sleep, and also to discard the junk food in the regular meals along the week. Special attention has been paid for the salt consumption because, as we said earlier, we had 9 grams on the average consumption of salt per day, which almost doubled the necessary requirement. And people right now became more alert that it's not only the sodium chloride, but also other forms of sodium are to be considered and reduced in their diet. The campaign focused upon the healthy Mediterranean diet and also revealed the comparison between the Mediterranean diet and the Western or the junk food. And as for the elderly, there has been great focus to make the elderly understand that their food has to be more vegetable-based rather than being based on starchy food. In phase 2, screening for school children revealed the high prevalence for overweight and obesity, as well as underweight and stunting as well. However, we went into a very good area where we attacked the physical inactivity in schools by making it part of the curriculum that became right now a pass or fail. And all the national schools right now have to have a special program for physical activity and even playing yards for school children to work upon. And it also included in some of the schools or some of our private schools the selectivity of purchasing from the canteen and training the young children or the adolescents how to purchase the healthier choices, even if they were not supervised, and why. Our campaign here in Egypt, the national campaign for 100 million health, went to the community in their localities, and we were explaining to people the benefit of better health, the benefit of reducing their weight, the benefit of reducing simple sugars, and how smart they should be at becoming more physically active and become inclined for the regular health appraisal at the primary healthcare destinies close to them. And I might highlight here that Egypt is privileged with an extensive, big coverage of a primary healthcare network that includes more than 5,000 primary healthcare facilities, all of which are within a walking distance of less than 3 kilometers in all the villages all over Egypt. And came about was the national campaign. Within this national campaign was the mobilization of the university students. The national university students were also educated, and they were trained to transmit the messages peer-to-peer and from their own selves to the community. And this was a very big mass move, which is very important for our country right now. Currently, we are speaking about the national breast screening, and national breast screening in Egypt has started many years ago, like 15 or 16 years ago, but right now it is intensified, and it is following a village to village and a district to district and a governorate to governorate coverage, where all women in the fertile age group are offered a chance to get with the mammography in the mobile units and in the fixed units, and they receive the treatment upon the discovery of any breast cancer. Our national action plans, together with Egypt's Vision 2030, are aligned with the WHO recommendations and Sustainable Development Goals. National commitment promises health promotion and better health outcomes in the near future. Thank you very much.
Present.
All right. Could I introduce him?
Let me. Okay. Let me.
Okay, you introduce him. Introduce him. It's okay.
I'm glad to present Professor Giovanni Guraldi. He's an associate professor of infectious disease at University of Modena and Reggio in Italy. At the year 2000, he started a liver and kidney transplantation for people living with HIV. And since 2002, he runs a metabolic clinic for HIV infection, providing care for more than 4,500 people. He is a panel member of the European AIDS Clinical Society guidelines on prevention and the management of HIV-associated comorbidities. Professor Giovanni will give us an interesting talk about the shift of dolutegravir and tenofovir alafenamide in low and middle income countries with a high prevalence of obesity. So please, Professor Giovanni.
So good evening, everybody, and thank you for this kind introduction. And also let me thank for the previous speakers, because both of them really helped to introduce this topic, and they did really great job to have an overview of many of the issues that we will discuss in my talk. The title is quite complex, but actually I will, these are my disclosure, I would like to go into the clinical management. I'm a clinician, I work all my day in an HIV clinic, and so I will get you through my clinic. I will present you a case. The name of this guy is Paolo, and I started visiting him in 2007. A good thing is to take pictures of patients, and I routinely do, and it was quite striking for me to go back and see what was my first picture I took of Paolo when he was in my clinic the first time. And you see that if you look at the table, it's quite impressive to see that in these 12 years, the weight of Paolo actually increased, and he was normal weight and he's now obese. But what is more interesting is that even when he was normal weight, the level of visceral adipose tissue was already high, 236. Remember that 150 is still a big cutoff when we describe central fat adiposity. And now is actually even more, 311. And of course, this can be depicted by the fact that the waist increased, but also, let me say, the fat was not just in the abdomen, was actually in the good place, in the leg, because actually Paolo was able to revert his previous lipoatrophy. So all this table tells me that there's a continuum in the anthropometric measures of my patients, and Paolo reversed his initial lipoatrophy that was associated with his pre-heart and early heart regimen. And nevertheless, I'm very much concerned, and Paolo is very much concerned as well, because of his central fat accumulation and, of course, obesity at the same time. So let me tell you something about Paolo. And so Paolo is infected for more than 20 years. He had a very low CD4, and the first speaker actually told us that this may be a signature about his risk to develop obesity as well as lipodystrophy, let me add. And now he's got quite good CD4 cell count. Nevertheless, the CD4-CD8 ratio is still far from being normal. And once again, we'll learn that this kind of immunological marker, better than the total CD4 cell count, describe something about the immune metabolic condition that Paolo is presenting us. Let me say, is this related all to HIV? Presumably not, because if you go to see what is the lifestyle of Paolo, you realize that he drinks too much. He has, luckily, no smoking habits, but actually he is sedentary. He's not doing any physical activity, and I believe this is bad for him. The issue is that his obesity may be a disease itself, but actually may be also risk factors of other comorbidities that we already discussed tonight, that is hypertension, NASH. Actually, he received a liver biopsy to diagnose NASH, lipodystrophy, dyslipidemia, osteopenia, and depression as well. And let me say, more and more we understand that the issue in HIV is not comorbidities, but rather how comorbidities mix in very complex multimorbidity patterns, and we need to study more how the clusters of these different comorbidities really behave. Of course, this produces the fact that Paolo is turning to be fragile, he's turning to be vulnerable, and speaking a better geriatric language, we can say that Paolo has got several geriatric syndrome, including polypharmacy, including fall, and including frailty. And I don't want to get into this, but really understand that more and more whenever I discuss the complexity of the patient, there's on one side the HIV virological complexity, there's the complexity that is related to comorbidities and multimorbidity, but there is also the complexity related to the biological age of the patient that can be described with frailty and the geriatric syndrome. Let me say, is there an impact of antiretroviral in this kind of anthropometric changes in the onset of comorbidities, in the onset of frailty in this guy? And you can see that actually he's been exposed to very bad drugs. Nevertheless, they were the only available at that time. We are trying to do something to change the regimen. We also tried to reduce the number of drugs, to, let me say, to deprescribe antiretroviral into dual therapy. You see dolutegravir 3TC, it's quite a popular drug, and we believe it's got quite neutral metabolic effect, but nevertheless, apparently, this was associated with the highest increase in body weight in this guy. But as I told you, also before getting obese, he already had a central lipodystrophy. And so you see how complex is obesity in the context of a pre-existing lipodystrophy as well. But also I'm trying to change because Paolo is asking me, I don't want that drug anymore, please give me something. And I really don't know what to give him. And so we will discuss, are the new available drug making sense even if we do not have randomized clinical trials regarding new potential regimen. Here I'm giving raltegravir doravirine. Let me say, I cannot recommend this because I got no randomized clinical trial, but nevertheless, this is to say, again, as a clinician, many times we are asked to do something also in the absence of an evidence-based situation. As we already said at the beginning of this evening, there's evidence that says that HIV drugs play a role. All this started in 2017 when Norwood told us that there was a difference comparing efavirenz and dolutegravir-based regimen. And actually, this was verified in much larger database in randomized clinical trial on naive patients, in which what was apparent that there was a INSTI effect that was more significant within some INSTI, but definitely there was a difference between INSTI-EPI and NNRTI regimen. But the backbone is not neutral. These are the data from the OPERA cohort that Paddy Mullen presented, that again, there is some effect of early switching of TAF whenever you change the regimen, particularly when TAF is associated with INSTI. And so again, we need to understand that not one single drug, but the regimen as a whole may have an impact. Well, how can we address all this in Africa? Well, it's not unusual. the fact that Africa can provide us exceptionally good clinical trial. To me, actually, the advanced trial has been one of the best to describe immune metabolic and anthropometric changing in people living with HIV. Of course, is Africa specific. We need to understand how to translate into non-African population, but tonight, we are here to describe the impact of these results in your, not rather mine, but in your clinical practice. Let me say also mine, because actually lots of African people are followed in my clinic now. It's a huge study, almost 1,050 people, and actually all these were treatment naive. They had not to have TB or pregnancy, and they were switched through 3 possible regimens: TAF-FTC dolutegravir, tenofovir-FTC dolutegravir, and tenofovir-FTC efavirenz. This is a very interesting issue because, as it was said in the introduction, we are making dolutegravir be first line in Africa, and we need to know how to compare with the standard of care, which has been efavirenz for many, many years. The bottom line from the viroimmunological effect was that at week 48, both dolutegravir and efavirenz were equally good, very high proportion, above 85% proportion of people with undetectable viral load. Let me say what was peculiar of this study that make us learn a lot from it. First of all, it's one of the very few studies in which we have a huge proportion of women. All community, scientific community says we want clinical trial in which women are represented. Look at here, above 50%, above 60% in some arm were women. And let me say, they were quite young people. The median age is 33 years, okay? And you can see that at the baseline, the proportion of obese people was 10-14%. And so let me say, maybe even lower than what is expected in the general African population. This is the graph that actually struck most of us because actually it contains 3 messages. The first message is that you cannot compare men and women because they are different. And apparently what happened with regard of increase in weight gain was definitely higher in women when compared to men. The second issue is that within each picture, you can see that there's a difference among the 3 different regimens. The INSTI, in particular, dolutegravir with TAF, compared with dolutegravir with TDF, and compared with efavirenz. So there is somehow a gradient of risk associated with drugs. And the third information is that differently from what we knew from registrational trials that I presented you before, here we do not see any plateau in the increase of weight gain. And so this is very important because actually we need to know in the future what will happen to all these individuals, because of course it's quite impressive to see that in the dolutegravir TAF regimen in women, there was an increase of median increase of 10 kilo, which is quite impressive. And if you go to get the percentage of individuals who develop obesity at week 96, it's actually 28% in the first drug regimen, the TAF dolutegravir, in women, and 7% in men. Actually, this is quite important. Nevertheless, we need to understand always to contextualize, is this so much different in the comparable HIV negative population? It has already been said that Africa have a quite alarming epidemic of obesity in the general population. If we compare with NANE's data in Africa, actually that's not huge. But what was really striking is that there is also a, let me say, a different psychological perspective about this, because in this survey on 68 participants, mainly women, what was quite funny is to see that 84 of people that actually gain weight were happy about that. And so really we need to understand, were they rather looking for that? Were they doing something to avoid that, if ever? They do like it. And there may be cultural issue. There may be, for instance, the idea that HIV disease produces wasting. And so if you get weight, you are less recognizable because of HIV. And so actually, I think all this make it difficult to interpret the data. But let us go into the anthropometric data about the advance. And you see that what happened, it was that both the lean and the fat increase, but with regard to the fat, both the subcute, and this is good, but also the visceral adipose tissue increased. And we've seen the same gradient of risk, dolutegravir TAF, dolutegravir TDF, and efavirenz TDF. And actually, this was similarly coupled with an increased level of dyslipidemia. In this case, and it was one of the few cases in which also the weight gain associated with INSTI was associated, in fact, with also the dyslipidemia, but then we can recognize that there is somehow a protective effect of tenofovir, which is not displayed by TAF. Given that, actually, I wanted to show you some sub-study that has been done on the advance that were presented last July in the International AIDS Society meeting from Andrew Phillips. And what you can see, it was quite a significant increase with regard of the prevalence of metabolic syndrome in this situation. And you can see that metabolic syndrome is a risk factor for cardio and diabetes risk. And so actually what it has been done was to understand if people that were included in the advanced trial had in fact an increase in the risk of cardiovascular estimate of the risk. And what I can tell you is that this was not really apparent because of the fact that you see that the increase in the Framingham risk score, of course, we do not have event, we can just forecast event using an algorithm, was not significant. On the contrary, if you go into the, let me say, level of diabetes and you want to forecast diabetes, in fact, the weight gain was associated with an increase probability of diabetes with the same gradient that we had. And so let us put all this in perspective. Do you think that the guidelines of WHO for Africa should consider this information, and to what extent we believe that now the first regimen should be dolutegravir tenofovir? I believe is still a very good choice when compared to dolutegravir TAF. And we need to understand that tenofovir may be toxic, especially with the bone to the kidney, but nevertheless, it will protect from some of the weight gain phenomenon, or rather the metabolic phenomenon that may be associated with this regimen. And so in conclusion, actually, the advanced trial was associated with a significant higher risk of clinical obesity, with metabolic syndrome, with rise both in SAT, but what is more alarming, in VAT. The predicted risk of myocardial infarction was not significant, while there was an increased risk of diabetes. And this analysis, I think, should be reported and repeated for other studies, including TAF and FTC and integrase inhibitors in other patient population as well. We need to learn from this trial how to have a better trial also in Europe. What has been done in the last CROI is to similarly analyze the data from the European big cohort about cardiovascular assessment in people living with HIV, which is the DAD cohort. And actually, we tried to see in a very large observational cohort that is of 43,000 people, what was the risk regarding the myocardial infarction and the diabetes according to different baseline BMI category. And actually result demonstrated that an increase in BMI, that is what we expect when we increase weight, across all levels of baseline BMI were consistently associated with increased risk of diabetes, but not with increased risk of cardiovascular disease. We can discuss, is the observation time enough? Is the age of the population good to address the cardiovascular risk? Yes or not? We also tried to answer another question. This is a poster I presented at CROI as well. And actually, I tried to understand if there was a contribution of traditional and HIV-related risk factors. And actually, I asked to analyze using what we call a population attributable factor to quantify what was the impact of rather switching to integrase inhibitors or rather improving your lifestyle with diet or with physical exercise. And actually, you must read like this. And so what the proportion of risk should be avoided if ever I was able to do something, that is, for instance, to have a better physical activity, to have a better diet, or not to change into an INSTI group. And actually, what it's apparent from here is that presumably all what we see is a multifactorial process, but nevertheless, we must understand that there is a gradient. And so what is more risky with regard of weight gain is rather the sedentary life, is having less than 600 METs. METs is a measure of physical activity, and 600 is quite low. And so it means that really, if our patient just do some physical activity, the best, but you don't need to do extremely physical activity to reduce the probability of gaining weight. The second is the diet, and the least is, in fact, the antiretroviral switch. Well, we would like also to have a better information regarding new drugs. I told you that I had to do something with my patient, and actually I went to the new drugs. So what the effect of new integrase inhibitors, and now we are looking at the fact that cabotegravir apparently is not associated with weight gain. But what regard, on the contrary, to the next generation of an NNRTI, and actually this is the new drugs that is available to us. We know already that the drugs is extremely potent. There's not non-inferior efficacy when comparators. And actually, we wanted, this study wanted to compare the effect of doravirine, darunavir, and efavirenz. And luckily, we don't have the comparison with regard to INSTI, but nevertheless, we can still, let me say, mix together 3 big randomized treatment-naive trials that actually allowed to compare face-to-face doravirine, that is an NRTI, with a PI, with efavirenz again. And actually, if you see the proportion of people that actually change their body weight, actually the body weight increase is really low. It's less than 2 kilo over 96 weeks. And so this is quite impressive. And what is really interesting is that actually there are, again, some immunological factors that are associated with this mild but still increase in weight gain. And this is an analysis that concentrated in the proportion of people actually who gain the most, that is more than 10%. And actually you see that baseline CD4 and baseline viral load were the only predictors of the long-term high increase on viral load. And this tells us that if we can early diagnose people, early initiate antiretroviral, this phenomenon will be reduced. Actually, these are some infographics, quite interesting to address according to the 3 different arms, where does the people that gets into obesity comes from. And let me say, according if you are underweight, according if you are normal weight, and according if you are obese. And so let me say, I hope that this is the case of my patient. Some patient like him from obesity, whenever I switch into a doravirine associated issue, I will have somehow a reduction in body weight. And so as a conclusion, the study told us that weight gain over 96 weeks was low in all treatment arms in this situation. And remember, there were no INSTI here. And the median weight gain was 1.5 kilo doravirine across 96, and was very similar to the efavirenz group. And low CD4 and high viral load at baseline were associated with the most increase in weight gain. Of course, there are study limitations that I already mentioned. But let me introduce the last and final part of my talk. Actually, we spoke so far actually about body weight and body fat quantity. But let me introduce the fact that if you go into literature to see to what extent sorry, what is happening here? HIV. And so this, I don't know how to stop because this was a previous talk I gave at AX, and what you can recognize is that, let me go to the right slide, sorry about that, the fact that if we wanted to measure the density rather than the quantity of visceral fat, we gain one information more, because of the fact that it's important to distinguish if the fat inside your abdomen is rather a fat hypertrophy. It means that your fat cell, your adipocyte, enlarge because they are full of triglyceride, or rather the density, and in this situation, the density go down. Contrary, if I've got a more inflamed fat, that means that actually I have some macrophages initiation. So bearing this in mind, will somehow increase the density. And so actually our study was really how to assess the ectopic fat quantity and density in a proportion of people in which we were able to, let me say, either switch antiretroviral therapy or not. And to do so, actually, we really had, sorry, it's got confused about this. I don't know how the sound gets in my back. But actually, just to go back, what I want to tell you is that we compared two groups. One group was INSTI naive patient, and one group of people in which it was people who switched to INSTI. And let me go direct to result, just to tell you that actually what we really found was the possibility to measure the fat quantity and the fat quality. You can see that a higher BMI was acquired in the and let me go straight to the conclusion, because actually there is this issue I could not imagine it was occurring. Sorry for that. I believe that now. Let me go back and let me talk on that. If you look at the baseline characteristics, you recognize that our two groups had similar age, approximately 50 years, and all of these individuals are in good immunological condition with more than 500 CD4 cell count. On the contrary, if you see measures of fat quantity, you recognize that these individuals had not that high subcutaneous adipose tissue at baseline, but a pretty high value of visceral adipose tissue volume as the contemporary, the level of attenuation was quite low when compared to this. This is underlying that presumably a lipodystrophy phenomenon was already present in this. If you look at what happened in the follow-up over a 4-year period, a similar proportion of individuals, 51 in the INSTI-naive and 57 in the switchers, actually gained. Let us go into detail to see the measure of fat quantity in the subset of the weight gainers. You can see that a higher BMI was acquired in the INSTI switchers, okay? Nevertheless, still in this group, the proportion of obese individual is not that higher than what is expected in the general population. And if you see what happened regarding the total lean and total fat, you may recognize that this increase in BMI is due to the fat component and not the component. But what is interesting is that even if this individual may have higher BMI, they do not acquire higher fat, which is not the difference, but rather higher subcutaneous adipose. And at the same time, both of the two groups had similar reduction in liver to spleen ratio, somehow suggesting a reduction in. If we get a measure of fat quality, it's impressive the reduction of visceral adipose tissue density in the INSTI switchers, somehow suggesting an improved fat quality. On the contrary, there was a similar reduction in subcutaneous adipose tissue density in the two groups, again suggesting improved quality. And so altogether, my conclusion is that over a 4-year period interval, people living with HIV who experience a weight gain actually were different. And INSTI switcher had greater gain in BMI, but actually this was driven by good fat, that is the subcutaneous fat. But there were no differences in the change of ectopic fat depot, in particular visceral adipose tissue. And the difference in fat density that was associated with INSTI does not suggest a metabolic abnormal fat gain in INSTI switchers, but may us even hypothesize an improvement in fat tissue quality. I believe that nowadays what is important is to identify among the weight gainers that are both people with lipodystrophy or just lipohypertrophy, who are the proportion of people who have increased fat and increased abnormal fat that may be different in these two phenotypes. The first presumably associated with increased cardiometabolic diseases, the second presumably. And this is, for me, the irony of success in people living with HIV. Thank you so much.
And so sorry for this technical issue. I did not realize that I taking the slides I presented a few days ago as a pre-recorded for the Glasgow meeting. Actually, may had reproduced. It was quite funny to listen myself while I'm still there. And so it's my first playback conference. And thank you for your patience. Thank you so much.
It was very nice.
Thank you, Dr. Giovanni. Thank you all our distinguished speakers. So now I'm leaving the floor for Professor Rina if she needs to open the discussion with the speakers.
Thank you, everyone, and thank you to all the speakers for such amazing presentations. So we can start the discussion. I have a couple of questions. Let me start with the last speaker, Professor Giovanni. Excellent presentation. I was very intrigued with what you said about your patient gaining more weight on a dual drug therapy. What are your thoughts on it? Are you going to, I mean, the world is moving to 2-drug therapy, and you're saying that your patient gained more weight on D3, the D3 regimen. What are your thoughts about that? Why do you think that happened? Because here we are thinking it's a combination TAF-DTG, which is causing weight gain. But seems that could it just be the D3 component of it? What are your thoughts?
Yes, this question, of course, this is a very important issue because, as you said, we are trying to understand what's the good and the bad in going into a 2DR or rather 3DR regimen. My personal opinion is that we need both 3DR and 2DR regimen. Let me stress anyhow what I try to say, that is, mind you, whenever you see weight gain is always a multifactorial phenomenon, okay? And so the drug is just one part of the story. The very easy part is that what happened to Paolo is that 12 years later, he was 12 years older, okay? Let me say, we stressed so much that there was an immunological risky condition in this situation, okay? Let me say there were also social behavioral condition. I told you that actually he's got a very bad lifestyle. He's not doing any physical activity, and in the past he's drinking too much, and also he's so much depressed, so that because actually his family issue he was divorced and he was alone and blah, 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 and all this definitely contribute. Nevertheless, I can tell you that dual dolutegravir drugs are not innocent with regard to this issue. And so, of course, I'm more worried if dolutegravir is associated with TAF, but let me say, dolutegravir alone, even in a dual regimen, has been shown, and my patient is one of these cases, to produce rapid weight gain, especially when you start this issue. And so I think that counseling before any antiretroviral switch should comprise weight gain prevention measure, and make the patient be aware, make the patient, let me say, be also able to accomplish the fact that something must be changed in their lifestyle in order to avoid this. Personally, I believe, according to my previous speaker, that lifestyle, including diet and physical activity, should be reinforced as an important message in our patient. And this should be the key to prevent the weight gain issue in people living with HIV.
Thank you. Any other? I have a couple of questions, but any other questions to my co-panelists?
Go ahead, Professor Rina.
Yeah, I actually wanted to support Professor Giovanni's earlier comment. Here in Africa, we associated HIV/AIDS with slim disease. In fact, the initial publications that went out for in the 1980s was HIV/AIDS is a slim causing disease. So the perspective, the perception of the people, most of the people was, if you are seen as slim, then you have HIV. And that has led to a lot of feeding and eating so that people gain weight and are known to have HIV. So it's multifactorial, the weight gain in some of these people, but mostly in the region I work in and with the Africans I work with, some tend to eat, and when you go to HIV/AIDS clinics, initially those we run around here, we would have a nutritionist who would add on to this and give them all sorts of multivitamins, all sorts of trace metals and other rich foods rich in protein and rich in other in fat, so that they could gain more weight and be seen to be doing quite well. I'll follow that with a question. Probably that could be again to the last speaker. Professor Giovanni. I wanted to find out age. Is it true that the older you that HIV/AIDS gives you a faster pace to aging? And if so, why? Is this through this metabolic theory, or is it through a different mechanism?
Oh, thank you. I mean, this is a $1 million question because of the fact that I believe that aging, let me say inflammaging, this is where my background comes from. My professor of immunology was Professor Franceschi, that was the first in the world that introduced this idea of inflammaging. Actually is very much linked to the anthropometric changes. And if ever we believe that HIV is quite a unique model of aging, okay, we must acknowledge that HIV has always been a disease associated with anthropometric changes. You mentioned HIV was initially described as a wasting condition. Okay, then we had all the issue regarding lipoatrophy, lipohypertrophy, and now obesity. And so I can see somehow a spectrum of all this that for sure have got association with the incredible immunological changes that we've been seeing. And so imagine now I'm quite embarrassed. I've been many years with people that were around the 300 CD4 and we were pretty satisfied. And then there was the reach about 500. Now I'm somehow embarrassed to say a person, well, your CD4 is 1,500. Okay, it's more than me. What does it mean? Okay, I don't know what does it mean. I truly believe that we still don't know what are the long-term immunological aspects associated with a long exposure to antiretroviral. And so, again, this is important for our HIV patient, but is also relevant for the general population because I believe that HIV is teaching a lot regarding what are the general drivers of aging in the general population. Okay, and so I believe that actually we need to study a lot of this phenomenon, to what extent anthropometric changes are associated with the aging phenomenon. But in this concern, let me introduce one issue. Don't think that fat adipose tissue is alone. Anthropometric means fat, lean, and bone. And we need to consider these three tissues at the same time. I cannot describe the visceral adipose tissue increase if I do not describe at the same time the sarcopenic phenomenon. And so I'm doing DEXA every day to all my patients. And when I started to go back to see the lean mass change over time, let me say, is even more impressive than the fat gain. Our patient most of the time lose 1 kilo lean mass a year since from the age of 35 or 40. And this is something we do not attention so much. This is why our nutritional expert must teach us how to prevent sarcopenia. This is incredibly important. How the prevention of sarcopenia will somehow help us to avoid the metabolic issue associated with NAFLD. Because remember that lots of the metabolic aspect that the liver does, also the muscle can do. And so really we need to better address the anthropometric changes as a whole. It's not just an issue of fat, it's an issue of the bone, is an issue of the lean muscle as well. Thank you for this very interesting question.
Thank you.
Maybe our also speaker wanted to comment about this. I think they did a great job to explain the association with NAFLD and with the nutritional aspect about how to improve the health of people living with HIV as well.
I want just to add a comment here for our Egyptian patients. Here in our HIV clinics, we are concerning about the CD4 count, the viral load, the treatment, and renewing the drug of the patient. Now, the maximum consideration may be about the bone metabolism. I think the part of the nutrition is not considered at all. The anthropometric measures, I think no time to be done in our clinics. it needs a specific clinic or a specialized clinic. The patient needs time to stay with the patient and do all these measures and hear the patient, take these measurements gradually and regularly. And of course, to incorporate a medical nutritionist. This is a very important, very, very important to consider the medical nutrition in care of patient with HIV. I think, Dr. Amga, this is missing to some extent in our general clinics, and it must be added or taken in consideration because, as our great speaker said, we don't need to shift the drugs or change the regimen if we consider the lifestyle modifications and the nutrition. So I think it must be considered in our HIV clinics. And I want to thank you very much for your excellent presentation, Professor Giovanni.
Dr. Ahiba, for this nice comment. In fact, so with the reconstruction of the scientific committee of HIV AIDS program in Egypt, we'll consider the nutritionist and nutrition issues of the people living with HIV, inshallah. You know, we are just starting a new program and we are developing our capabilities, inshallah, soon. Inshallah.
Let me put one little piece of my small but beloved experience of Africa. I've been working for many years in Tanzania. And there's some very easy anthropometric value, waist circumference, cost zero. It takes a few seconds to do it. But let me say, it's still the best marker of visceral adipose tissue we have. And it makes sense to measure because of the association with the insulin resistance, the association with NAFLD, and altogether the association with the immune metabolic changes to me are very good. And so I believe that actually the introduction of information regarding not just weight, but also waist circumference will add a lot and will allow also to make the definition of metabolic syndrome at the same time.
Yes. In the score of fatty liver index, we use the waist circumference, and it is an easy thing to be done instead of the CT scan or the MRI or whatever. Simple and easy method to assess this point. And I hope we can apply this for our patients, inshallah. Thank you very much.
Yes, allow me to add something, Dr.
Yeah, go ahead. Go ahead.
That here in the university hospitals, in most of hospitals in Egypt, we don't have a medical nutrition therapy unit. And the patients upon admission are not nutritionally assessed. And also upon their discharge, they are not nutritionally assessed, and they are offered more or less a hotel-like diet that's all in all healthy. And what we know about in the hospital kitchen is that we speak about low-carb diet and about low-salt diet that is not properly identified. And in Egypt in general and in our faculties of medicine, we lack the medical nutrition therapy units or departments. And this has made us think about what can we nationally do. We have the National Nutrition Institute in Egypt that is attached to the Ministry of Health. And into the Ministry of Health, we have developed the Nutrition Board or Nutrition Fellowship, in which there is a study for 3 years, but it only accommodates like 35 to 40 students along the year, and they get graduated in 3 years, which makes them a rarity to fulfill the need for the nutritionists all over the country. However, this could be started on a local scale in the Cairo University Hospital with an efforts to combine work between the public health department and the tropical medicine department to start this nucleus of nutritional assessment and paired teamwork on a small scale between two departments. And I can offer help in this area until we have a well-formulated clinical nutrition unit in our School of Health.
Could I add something?
Sure.
Professor Lule wanted to add something. I wanted to make a comment and a question In my own experience, working in a liver unit over many years, I've found lifestyle modification an extremely difficult thing. Yeah. Most of our patients in the liver units, whether they're HIV or not HIV positive, some of them tend to be smokers, they drink alcohol, and we spend years trying to make them change, and they actually do not. So lifestyle modification, maybe we've been helped a little bit by having treatment for HCV infection. But apart from that, trying to modify patients' lifestyles, sometimes I find it quite difficult. I'd like to hear about the Egyptians, how they find their own patients. My question goes to Professor Shoki Maisa, I think. She talked about statins in the control of either dyslipidemia or even pushing it down to metabolic syndrome. Would she recommend routine use of statins in most of these patients, especially on traditional drugs, not the newer drugs, especially to deal with a significant reduction of their dyslipidemia? Would you recommend the routine use of statins in patients with HIV?
Well, maybe it's Dr. Heba who discussed the issue about statins in her presentation. But let me tell you something that lipid-lowering drugs usually have side effects. And they have to be paired with an ongoing intake for like 6 months till up to 12 months. And usually they induce muscle dystrophy and muscle aches all over the body that makes the patient refrain from taking them. On the other hand, it has to be paired with the nutrition education for the patient to select the healthier kind of fat, which is the polyunsaturated and the monounsaturated fatty acid, and to make it an easier choice for them to include in their diet and to exclude whatever is inclusive of the saturated fat and the trans fat as well. When we speak about statins and we speak about lipid-lowering drugs, we're speaking about lowering the lipids in the blood. But this usually needs a very long time until it reduces the cholesterol patches or the atherosclerotic patches that are entering or seriously adherent to the intima of the blood vessels. And so even if we prescribe statins, I'm not a physician, by the way, I'm a public health specialist, but through research, you find a prescription of statins is not welcomed among the Egyptian population. It's very costly unless it's included on the national health insurance. And at the same time, people refrain or discontinue its use upon its side effects. What brings about more beautiful and sustainable results is to change the behavior, and this actually needs more effort and becoming more focused about what are the pitfalls that the patient is doing and how to revert them, and to revert them willingly upon the patient's behalf.
All right.
Thank you. Any further comments or questions from the panelists? If not, I have one, and maybe Professor Giovanni and Professor Lule can even expand on this. As WHO countries, we are now transitioning from efavirenz-based regimens to dolutegravir-based. In fact, we've been told that in a couple of years, we probably won't have efavirenz available because countries are just not ordering it. Do you think we will be getting lots of metabolic disease, or will we be getting the obesity associated with the integrase inhibitors? Is that something we need to look out for, or do we feel that we'll manage without it?
No, I don't, because actually what is more urgent is to scale up antiretroviral therapy for all the people who need it first. This is the first thing to do, the most urgent thing to do. In Africa, there are still 50% of people that should be on antiretroviral and are not. This is really urgent. Given that is our first aim, we need to offer the best drug we have. And so I believe, and actually this was our clinical experience, that the switch from efavirenz to INSTI-based, I don't say necessarily dolutegravir, but INSTI-based is a good choice. Remember that actually efavirenz has got its own side effects, Okay, some of them are really very bad. Remember the suicidality associated with efavirenz. Remember the neurocognitive impairment associated with efavirenz is not trivial. Of course, there may be also with some INSTI and dolutegravir in particular, but the comparison is not really there. And so to me, I think it's urgent to, especially in this COVID pandemic, not to slow down the urgency of scaling up antiretroviral therapy and to offer the best treatment to Africa. And so it's really no more acceptable that in Africa we've got some standards of drug safety. In the rest of the world, we've got other standards. This has got no way to go further. The issue about weight gain is small like this, comparing to the issue of not scaling up drug, and is urgent that we go with the same direction of the Western countries. I cannot accept any more than when I go to Africa, I use the drugs that I was using 15 years ago when I was in my country. This is no more acceptable. Okay, and we need to work about that. Given that, there's problem. There's problem in Africa, there's problem in Europe, there's problem in US, and we need to continue to do research. And remember, Africa now has got the best potential to give the best research quality we need to do. This is my opinion.
Thank you very much. And I wanted you to elaborate on that, because I think often we get questions saying that as we're scaling up, what about the issues with integrase inhibitors? And I really want that to come out. We in Kenya have had integrase inhibitors before even some of the European countries. So I personally have used dolutegravir for the last 5-6 years and used it very effectively. So in my practice, I have transitioned most people over to integrase inhibitors, except the few that do get the complications with integrase inhibitors, which are mainly either skin rashes or neuropsychiatric, but they're very, very few compared to what's been described in the West.
Very small comment about that. What is the difference when we think about treating in Africa and treating in Western countries? Is that we still need to have for Africa a more public health approach rather than a personalized medicine approach. My view is that before we needed to address the public health approach, because it's for sure that all people living with HIV should go into antiretroviral therapy. The second step should be a more personalized approach in which there may be some people in which efavirenz is better than dolutegravir, but also remember, there's not just dolutegravir, there's also others, integrase inhibitors and other NRTI that must get into African market as well. And so we really need to first get the public health approach that is treatment for all. The second is to have a more personalized approach, having multiple drugs. I can choose to have the best drug for each patient. This is my opinion.
And we agree with that. I think I agree with that. It's just that now with the scale up and with the WHO, there may not be the options that we may be able to give patients who are able to pay versus patients in the public health sector where they'll only be offered like one regimen, because often the scale up and the rollout is done by a certain cadre of staff who may not be able to decide what to give the patient. So that is going to be a challenge in Africa. But I think it's unfortunately there is two levels of care in a lot of the African countries. There's the public sector and the private sector care. And in the private sector, they have everything. Even the newer agents we're able to get, and then there's the public sector. But those are the challenges of Africa. But having said that, we're very glad that we've got integrase inhibitors in the public sector, so the patients are getting the best that's available in the rest of the world.
Can I add, Rina? Can I add something?
Yes, Prof. Lule, go ahead. Thank you.
I definitely agree with both of you. I concur, as people say, there should never be two different types of drugs for the population in this world. It should be one recommendation, and probably with the modifications using public health approach and in a resource poor setting, trying to make the drugs more accessible to more people. However, what we learned in the earlier days, when people used to think that even the basic antiretroviral drugs couldn't be accessed in Africa because of poverty, we learned that the more people that use the drug, the cheaper it becomes. And a slight, during Piot's time in WHO, a slight shift in the manufacturer would make the drug 100 times cheaper in some countries. So we can change, take off the patents, and have some of these drugs manufactured in India or in other places, even in Africa, in Egypt, and would have them quite cheap. I think this had happened with the hepatitis C treatment drugs, and it can be copied in HIV treatment. So I believe in what Professor Giovanni has said. Everybody should have the right to access any drug, despite being poor. I wanted to ask something that might be slightly different from that. Again, I wanted to ask, in trying to treat obesity, I think in the US, do you have any experience with the growth hormone analog? I think it was tosametarin, which they were trying to put up for treating, and it appeared to relieve these obesity and weight problems at that time. I think it was approved by FDA last year or 2 years ago. Anything about that, Giovanni?
So I can answer regarding my experience. I do not have clinical experience of tesamorelin. Actually, I was involved in EMEA because I strongly recommended EMEA to introduce Egrifta in European market, and I failed. And to me, it was a very big issue because actually I thought it was a good drug to be used, and actually there's accumulating evidence of the fact that this is not just an issue of obesity. Now we know that tesamorelin works for NAFLD. There's a randomized clinical trial about that. We know that it works for COPD. And so actually it's associated with an improvement on any immune metabolic condition that is associated with visceral adipose tissue. In my opinion, the drug has not been properly well developed in order to demonstrate the benefit apart from the weight circumference, which was, of course, a surrogate for better situation. Now we know that there are further studies that try to improve that. Given that this will never be a drug that could be available in the patient who most benefit for that. Remember, it still costs $30,000 a year. And this drug, as soon as you stop, you lose the effect in the long term. And so, I mean, tesamorelin is a good point of principle in order to say that is the direction where we need to go, but is a completely different level of availability. I will never have a patient that will be able to afford that in my clinical practice. And for sure, my country will not pay for that drug unless we do not prove that the benefit is so substantial, but the level should be the same that we ask for, I don't know, chemotherapy drugs for cancer. And so we are still far away from having this kind of drugs available in our clinical practice, I believe.
Thank you for that comment. Thank you very much.
Sorry.
So any more comments? Dr. Amgad, do you have any comment?
If this is the last comment, I would like to thank all the participants, professors and speakers and the chairpersons in this nice meeting. Hoping to see you, inshallah, in next meetings, inshallah. Thank you very much for MSD for sponsoring this meeting, and hope to see you all soon, inshallah, in our Uchid conference. So, thank you very much for all.
Bye.
Thank you, Dr. Amgad, and thank you all, dear professors. Bye-bye.
Bye-bye.